Welcome to the Radon Smart Review CNS Cancer series.
Great to be here.
We're here today to really dig into an essential topic in neuro-oncology. Meningiomas, now they're common, right? But they present some really complex challenges, especially when you get into the higher grades.
Absolutely. We're talking about the atypical and anaplastic forms, WHO grade 2 and 3.
Exactly. So our goal for this session is to dissect their management, look closely at radiation planning, and also touch on, what's coming down the pipeline therapeutically.
And this should be really valuable for you listening, whether you're prepping for boards or just navigating these cases day-to-day in clinic. We're really aiming for those high-yield practical insights.
Definitely. We touched on grade 1s before, the basics, epidemiology, WHO grading.
Yeah, the foundations.
But today we're stepping into, I guess, the more challenging zone, WHO grade 2, atypical, and grade 3, anaplastic. These really demand precision.
They absolutely do. So maybe we can outline our plan. We'll start with adjuvant radiation for these higher grades. Always a hot topic.
Good plan.
Then maybe pivot to re-irradiation strategies. That's becoming more common.
Okay.
Then we can share some really specific planning pearls, those little tips that make a difference.
Practical stuff. Love it.
And wrap up with the systemic therapy landscape. It's definitely evolving.
Perfect. And to ground this, let's use a case. How about this? A 58-year-old woman, history of seizures. MRI shows a dural-based mass. She has surgery. A Simpson grade 2 gross total resection.
Okay, so Simpson 2 tumor out, but dura coagulated, not fully removed.
Exactly. And the final path, WHO grade 2. Atypical meningioma, 8 mitosis per 10 high-power fields, and critically, no brain invasion.
Got it. So newly diagnosed grade 2, GTR, no brain invasion. That's a classic scenario for the big debate.
Precisely. That case will kind of guide our discussion on grade 2 management.
And maybe we can touch on, what if it was recurrent grade 2 or a new grade 3, just to cover the spectrum.
Yeah, good idea. Broaden it out. Okay, so let's build that foundation. WHO grade 2 meningioma. What exactly are the diagnostic criteria? How do we define it?
Okay, so WHO grade 2, it's defined primarily by the mitotic index. That's 4 to 19 mitosis per 10 high-power fields.
4 to 19, got it.
Or,
Oh, yeah.
and this is key, the unequivocal presence of brain invasion. If you see brain invasion, it's automatically grade 2, even if the mitotic count is lower.
Ah, the trump card.
Exactly. And then the third way is if you don't meet those first two, but you have at least 3 specific atypical features, things like prominent nucleoli, high cellularity, maybe sheeting architecture, small cell formation, or spontaneous necrosis. 3 of those, and it's grade 2.
Okay, comprehensive. And these make up what percentage of meningiomas?
About 7%. So not the most common, but definitely a significant subgroup we encounter.
Right. Which brings us, as you said, straight into the big debate. High yield for boards, definitely. The grade 2 gross total resection controversy.
Yep.
Our patient fits this perfectly. Newly diagnosed grade 2 GTR. So the question, radiate or not radiate? What's the argument for adjuvant radiation here?
Well, the argument for radiation is, honestly, pretty compelling. It's mainly driven by the recurrence rates if you don't radiate.
Which are?
Consistently high. Multiple retrospective studies, different centers, they all point to roughly a 50% local recurrence rate at 5 years. After a GPR alone for grade 2.
50%. Half the patients.
Yeah, think about that.
Yeah.
Within 5 years, half might have the tumor come back without more treatment. It's a substantial risk.
That's stark. It really highlights why observation isn't straightforward. And there's specific evidence supporting radiation, right? Like that Harvard paper.
Absolutely. The Iser paper from 2014, really influential. It showed that adding adjuvant radiation, typically around 60 gray, was associated with a hazard ratio for local progression of just 0.25.
0.25, so a 75% reduction in the risk of progression.
Exactly, a 75% reduction. That's a huge impact on outcome.
Massive. And then there's RTOG 0539. How does that fit in?
Right, RTOG 0539, the intermediate risk group in that trial. That's precisely these patients newly diagnosed grade 2 after GTR. And with adjuvant radiation, they achieved an excellent 94% 3-year progression-free survival.
94% PFS at 3 years. That's strong level 2 evidence, wouldn't you say?
Very strong. It really bolsters the case for radiating these patients up front.
Okay, so very strong arguments for radiation. But there's always a but. What's the case for observation? Why hold off?
Well, the main reason, and it's a valid one, is to spare the patient potential side effects from brain radiation, both short-term and long-term.
Like what specifically?
Acutely, fatigue, maybe some hair loss, skin changes. Longer term, the concerns are things like neurocognitive effects, maybe hearing issues, and the very small but real risk of a secondary cancer down the line.
So the idea is reserve radiation for salvage if it actually recurs.
Exactly. You watch closely and only treat if progression happens. The argument there is that maybe salvage RT offers similar control to upfront RT, but you avoid toxicity in patients whose tumors wouldn't have recurred anyway. It's that risk-benefit balance.
Makes sense. So where do the guidelines sit right now, given this debate? We know RTTG 0539 is level 2 evidence.
Right, but we're still waiting for the big level 1 randomized trials to really nail this down.
Those are the Rome trial in Europe and NRG-BN 003 in North America.
Correct. ROMI RTC 1308 and NRG-BN 003. Until those results are mature, though, the NCCN guidelines, they consider adjuvant radiation an appropriate recommendation after a GTR of a grade 2.
Okay, so it's a strong consideration supported by current guidelines pending level 1 data.
Precisely. Reflects the weight of the current evidence.
Let's dive back into RTG 0539, specifically Group 2, the intermediate risk group. Our patient fits here. Can you detail who is in this group again?
Sure. Group 2, intermediate risk, about 70% were just like our patient, newly diagnosed WHO grade 2 after a GPR. The other 30% were patients with a recurrent WHO grade 1 tumor. So either a new grade 2 GTR or a recurrent grade 1.
And the treatment protocol for them?
Adjuvant radiation therapy. The dose was 54 gray in 30 fractions.
54 in 30. And the outcomes you mentioned, 94% 3-year PFS, 96% local control.
Exactly. Which, again, compares very favorably to a historical series of surgery alone, where you might see 50% recurrence by 5 years. Big difference.
Huge difference. Now, the planning volumes for that group in the trial, super important for actually doing this. GTV, CTV.
PTV, right. So for this intermediate risk group, the gross tumor volume, the GTV, was the post-operative tumor bed, basically where the tumor used to be.
Makes sense.
The clinical target volume, or CTV, was the GTV plus a 10-millimeter margin. 10 millimeters all around to catch potential microscopic spread.
10 millimeters. But wasn't there a nuance about natural barriers?
Yes, good point. That 10-millimeter margin could be reduced down to 5 millimeters if it abutted a natural anatomical barrier. Things like bone, the falx, or the tentorium.
Right, to spare normal tissue where the tumor is less likely to cross.
Precisely. And then the planning target volume, the PTV, was a standard 3 to 5 millimeter expansion on the CTV for daily setup variation.
Got it. GTV is post-op bed. CTV is GTV plus 10 millimeter, reducible to 5 millimeter at barriers. PTV is CTV plus 3, 5 millimeter. Very clear. Okay, so that's GTR grade 2. What if it's a subtotal resection of a grade 2? Is there still a debate?
Nope, no debate there.
Yep.
If you have a subtotal resection of a WHO, grade 2 meaning gross tumor left behind adjuvant radiation therapy is definitely indicated. Standard of care.
And where does that fit in RTUG 0539?
That immediately bumps the patient into the high-risk category, Group 3 of RTOG 0539, radiation standard practice there.
Okay, so subtotal grade 2, high-risk equine radiation. Clear. Now let's move to WHO grade 3 anaplastic. These are the really aggressive ones, right? What kind of outcomes are we looking at, even with treatment?
You're right. These are the most aggressive. WHO grade 3. Even with surgery and radiation, the numbers are, well, they're sobering. We're talking maybe 60% 5-year relapse-free survival.
Only 60% at 5 years.
And it drops further. Maybe 40% 10-year relapse-free survival. It just underscores how aggressive these are and why we need effective treatment.
Definitely. So how did RTOG 0539 handle these in their Group 3, the high-risk cohort? Who was included there?
Okay, the high-risk group, Group 3, it included any WHO grade 3 tumor. Didn't matter if it was GTR or STR.
Any grade 3. Got it.
Plus, it also included WHO grade 2 tumors that were either recurrent or, as we just said, had a subtotal resection initially.
So any grade 3 or a recurrent STR grade 2. And the treatment, higher dose.
Yes. The prescribed dose for this high-risk group was 60 gray in 30 fractions, often delivered using a SIB approach.
Simultaneous integrated boost.
Right. Delivering different doses concurrently. A higher dose maybe to gross disease, lower dose to the wider CTV.
And how did these high-risk patients do in the trial? What were the outcomes?
Well, the outcomes really reflected the tumor biology. 3-year PFS was only 59%.
Oof.
Yeah. 3-year local control was 69%. And 3-year overall survival, 79%. Better than PFS, but still concerning.
And you mentioned something about where the failures occurred?
Yes, a really important finding. Over 90% of the failures in this group happened within the 54 gray volume.
Ah, suggesting that maybe even 60 gray wasn't enough for the toughest spots.
Exactly. It hinted that maybe dose escalation could be beneficial for these really aggressive tumors.
Let's pin that thought. First, the volumes for this high-risk group, especially with the SIB. How were they defined? PTV1, PTV2.
Okay, so two PTVs for the SIB. PTV1 got the 54 gray. That was defined as the GTV, any residual tumor, plus a pretty generous 20 millimeter CTV margin.
20 millimeters, that's quite large.
It is, to cover that wider potential spread. Then PTV2, nested inside PTV1, got the higher dose, 60 gray. That was the GTV plus a tighter 10 millimeter CTV margin. So boost the known disease plus a closer margin.
Got it. 54 dry to GTV plus 20 millimeters, 60 dry to GTV plus 10 millimeters. Okay, now back to dose escalation. You said the RTOG results hinted 60 gray might not be enough. Is there other data supporting higher doses?
Yes, there is. 60 gray is still largely standard, but there's definitely a growing discussion supported by retrospective data. For instance, a study by Zhang in 2023 looked at this.
And what did Zhang find? Is going higher better? Risky?
Zhang's study suggested it is better. They found that dose-escalated RT defined as 66 gray EQD2 or higher for high-grade meningioma significantly improved 5-year local control. Went from about 46% with lower doses up to 68%.
Wow, that's a big jump. What about PFS?
PFS improved too, from 41% up to 65% at 5 years. And importantly, this was achieved with what they reported as acceptable rates of radionecrosis.
So higher dose might be worth the risk in select high-grade cases.
It suggests that yes, for carefully chosen patients, pushing the dose might be feasible and offer better outcomes. It's definitely something being considered more.
Okay. Beyond radiation, what about systemic therapy? Especially for, refractory grade 2 or 3 or cases where RT options are limited.
Right. Systemic therapy comes into play there. It's an NCCN Category 2B recommendation for refractory grade 2 or 3, meaning it's an option based on some evidence or consensus, but maybe not as rock solid as Category 1.
And what are the options? What kinds of drugs?
It's a mix. You have anti-angiogenics drugs like bevacizumab or sunitinib targeting tumor blood supply. Then there are mTOR inhibitors like everolimus hitting a key cell growth pathway.
Any traditional chemo or newer targeted stuff?
Yeah, traditional chemo like trabectedin is sometimes used, but the really exciting area right now is probably somatostatin receptor targeted therapies.
Ah, because many meningiomas express that receptor.
Exactly. High expression of SSTR2. So agents like lutetium-177 dotatate, a radioactive isotope linked to a somatostatin analog, are showing real promise in early phase 2 trials. It delivers radiation right to the tumor cells.
Very cool. And immunotherapy?
Immunotherapy, things like nivolumab, pembrolizumab,
Huh.
they're being explored in trials too. Still early days to know their exact role, but definitely an active area of research.
Okay, lots happening on the systemic front. Let's switch gears to the practicalities of radiation planning, like a workshop. How do we set these patients up? Immobilization, imaging.
Standard setup is usually supine on their back, immobilized with a short thermoplastic mask. You want really good immobilization for precision.
Makes sense. Imaging.
CT simulation scan with IV contrast. And then, absolute critical, you fuse that CT with both the pre-op and post-op MRIs. T1 post-contrast, T2 FLAR. You need it all.
Fusion is key. Any specific MRI sequence that's extra important?
Yes. The T1 pre-contrast sequence is vital, especially for looking at bone invasion.
Why pre-contrast for bone?
Because tumor replacing the fatty marrow in the bone shows up dark, hypointense on T1 pre-contrast. It can be much clearer than trying to see enhancement within the bone itself. Really helps define bony extent.
Good pearl. Okay, defining the GTV, what goes in, what stays out?
GTV is the post-op tumor bed, plus any definite residual nodular enhancement on the latest MRI. Nodular enhancement.
What about edema or the dural tail?
Critically important. Do not include cerebral edema or the linear dural tail in the GTV, especially if you're planning in SIB. Those are usually reactive, not gross tumor. Boosting them just increases toxicity.
Got it. Edema and linear tail are out of the GTV. What about hyperostosis? That bony thickening often seen nearby?
Hyperostosis should be included in the GTV.
Really? Even if it's just thick bone?
Yes, because that thickened bone can actually harbor tumor cells. It's considered infiltrated bone, so it needs to be part of the target.
Include hyperostosis. Okay. Now, CTV margins. These seem to vary a lot. Can you walk us through the general rules by grade?
Sure, it does vary. For a WHO grade 1, If you're treating it, typically a 0 millimeter CTV margin. Just treat the GTV tightly. Maybe 0.5 centimeters if it's recurrent grade 1.
Okay, 0 for primary grade 1. What about grade 2 GTR, like our patient?
For a non-recurrent grade 2 GTR, usually GTV plus a 0.5 centimeter margin. But if that grade 2 has brain invasion noted on pathology.
The trump card again, bigger margin.
Yeah, if there's brain invasion, you increase that margin to 1 centimeter to account for that infiltrative potential.
Okay, 0.5 centimeters for grade 2 GTR, but 1 centimeter of brain invasion. And then for grade 3 or stroke recurrent grade 2.
For any grade 3 or any straight current grade 2, basically the high-risk groups, the CTV, is typically GTV plus a 1 centimeter margin for the main dose level, like the 60 gray. More generous margin for these more aggressive scenarios.
Makes sense. GTV plus 1 centimeters for high risk, and then the PTV margin on top of the CTV.
Usually a standard 3 millimeters, assuming daily image guidance like cone beam CT, CTV plus 3 millimeters for PTV.
All right. Doses for fractionated external beam, which you said is preferred for grade 2 plus. Can you summarize the typical prescriptions?
Sure. Fractionated is definitely preferred. For grade 1, if treated, usually 54 gray and 30 fractions.
Okay.
For a GTR of a grade 2, often 59.4 gray in 33 fractions, or maybe 60 gray in 30. A bit higher than grade 1.
59.4 or 60. And for the highest risk, STR grade 2 or any grade 3.
That's where we typically go to 60 grays and 30 fractions as the standard. And as we discussed, often with that SEB, boosting gross disease up to 66 or even 70 gray in 30 to 35 fractions.
Right, hitting the known disease harder. Any special case like optic nerve sheath meningiomas, dose constraints must be tight there.
Extremely tight. For optic nerve sheath meningiomas, you have to be much more conservative because of the optic nerve and chiasm right there. A common dose is 50.4 gray in 28 fractions. Prioritizing vision preservation is paramount.
50.4 got it. What about SRS, single fraction radiosurgery, or fractionated SRS? Do they have a role, especially in grade 2 or 3?
Generally a limited role for SRS in grade 2 or 3 as primary treatment. These tumors are often larger, more infiltrative, not ideal candidates for single-shot SRS.
Makes sense. SRS is more for smaller, well-defined grade 1s.
Yes, typically. A single fraction SRS dose for grade 1 might be 12 to 16 gray. Fractionated SRS, though. That can be an option sometimes.
When would you use fractionated SRS?
Maybe for small residual tumors after surgery, or maybe small well-defined recurrences. You might use regimens like 21 to 24 gray in 3 fractions or 25 to 30 gray in 5 fractions. Gives you some fractionation benefit, but still highly conformal.
Okay. Let's talk about recurrence. It's a big issue, even for grade 1s, right? And often triggers RT even after GTR.
It absolutely is. Recurrence is a major challenge. The data on recurrent benign meningiomas is pretty clear. If you just do surgery alone for a recurrent grade 1, the 5 to 8 year progression-free survival is really poor. Only like 10 to 30%. They just keep coming back.
Wow. Versus surgery plus radiation.
Big difference. Surgery plus adjuvant RT for recurrent grade 1, the PFS jumps up to 80 to 90%.
Huge improvement. Really underscores the need for RT in the recurrent setting, even for grade 1.
Absolutely.
So what if a tumor recurs after initial radiation? Is re-irradiation possible? What are the risks?
Re-irradiation is definitely feasible, and we're doing it more often, especially as patients live longer and these tumors can recur late. But it's not without risk, obviously.
What's the main concern? Cumulative dose.
Exactly. Cumulative dose to normal brain. There was an Italian retrospective study looking at this. They found patients received a median cumulative dose in GQD2, alpha beta 2, of around 106 gray.
106 gray cumulative. That's high. What about radionecrosis?
That's the main risk. The study noted a 2-year radionecrosis rate up to 20%.
Yeah.
So it's a significant possibility you have to counsel patients about.
20% risk of RN. What kind of re-irradiation doses or regimens are commonly used?
Often hypofractionated courses. Things like 35 gray in 5 fractions, maybe 30 gray in 6, or 25 gray in 5, trying to get a good biological dose efficiently.
And the margins for re-irradiation, very tight, I assume.
Extremely tight. CTV margin might be 0 to 1 millimeter, PTV margin 0 to 2 millimeters. Very focused, using techniques like SRS or fractionated SRS often to minimize overlap with the previous high-dose region.
Makes sense. Okay, let's broaden out to toxicity in general. Surgical complications first. Highly variable, I imagine.
Highly variable. Depends so much on tumor size, location, especially skull-based tumors. Morbidity can range from 2% up to 30%. Mortality maybe 1 to 14%, higher for complex skull-based cases.
And radiation-related issues. We mentioned radionecrosis with re-RT. What about radiation-induced meningiomas?
That's a rare but known long-term risk. About 3% risk at 30 years after initial cranial RT.
Is it higher in kids?
Much higher, unfortunately. For pediatric cranial RT, especially as given before age 8, the risk of developing a meningioma later can be up to 50% by 20 years post-treatment.
50%? Wow. What about edema after RT?
Symptomatic peritumoral edema can happen, maybe up to 35% risk with SRS for parasagittal lesions, for example. Fractionation usually helps mitigate this compared to single-dose SRS.
And secondary malignancy risk from the RT itself?
With modern conformal techniques, or SRS, it's estimated to be quite low. Around 1 in 1,000, maybe.
Okay.
But still something we mention.
Okay. Given all these risks and the potential for recurrence, what about follow-up? How often should we be getting MRIs according to NCCN?
It varies by grade, reflecting the risk. For grade 1, MRI at 3 and 6 months, then annually for 5 years, then every 1 to 3 years indefinitely.
Grade 1, 3MO, 6 Budo, annually by 5Y, then Q1 3Y. Okay. Grade 2.
More frequent, every 3 to 6 months for 5 years, then every 6 to 12 months indefinitely. Lifelong surveillance needed.
Grade 2, Q36 mammo by 5Y, then Q612 mammo indefinitely. And grade 3, even more frequent.
Yes, most frequent. Every 2 to 4 months for the first 3 years, then every 3 to 6 months indefinitely. Reflects that very high early recurrence risk.
Grade 3, Q2 mammo by 3Y, then Q36 mammo indefinitely. Got it. So thinking big picture, future directions. Where is meningioma management heading? What are the key controversies or advances?
Well, a huge one is resolving that grade 2 GTR controversy with the ongoing randomized trials. Getting that level 1 evidence will be critical.
Definitely.
Molecular classification is huge. Moving beyond just WHO grade to understand that tumors, genetics, TERT mutations, CDKN2AB deletions we mentioned for grade 3, other markers that will likely refine prognosis and maybe treatment selection.
More personalized approaches based on mutation.
Exactly. And then the therapies we touched on, somatostatin receptor targeted therapies like lutetium dotatate.
That sounds really promising.
It does. Early results are encouraging, especially for recurrent refractory cases, and then other targeted agents based on molecular findings, plus immunotherapy. Lots happening.
Okay, let's bring it all home. Applying this knowledge to our patient. Remember her, 58-year-old woman, Simpson grade 2 GTR, WHO grade 2 atypical, 8 mitosis 10 HbF, no brain invasion. What's the recommendation for her?
Okay. Based on everything we've discussed, particularly RTOG 0539, she fits squarely into the intermediate risk group 2.
Right. And the treatment for that group was?
Adjuvant radiation therapy to 54 gray in 30 fractions.
And the CTV for her?
Postoperative tumor bed plus that 10 millimeter margin, reducible to 5 millimeters at natural barriers like bone or falx.
So what's the bottom line reasoning you'd give her, acknowledging the observation option exists?
The core reasoning is the recurrence risk. While observation is an option discussed, the retrospective data consistently points to about a 50% chance of recurrence within 5 years if she only has surgery, versus the 94% 3-year progression-free survival seen in RTOG 0539 with adjuvant radiation for patients just like her. Given that large difference in control rates, adjuvant RT significantly reduces her risk of the tumor coming back and is strongly supported by the available evidence.
Makes a strong case. Okay, let's shift into high-yield takeaway mode, clinical polls. Ready?
Let's do it. Pearl number 1.
WHO grading specifics. Grade 2. 419 mitosis 10 HpF or R brain invasion or R3 plus atypical features. Grade 3, 20 plus mitosis 10 HpF or TERT mutation or CDKN2AB homozygous deletion. And remember, brain invasion is that grade 2 trump card.
Excellent summary. Pearl 2. Simpson grade. Remember that rough rule of thumb for WHO grade 1? 10-year recurrence risk is about 10 times the Simpson grade number. Simpson 1, 10%, Simpson 2, 20%, Simpson 3, 30%. Just a quick estimate.
Nice shortcut. Pearl 3, RTOG 0539, risk groups and doses. Use that mnemonic, LIHOFS.
Right. L low risk, new grade 1, gets O observation. I intermediate risk, recurrent grade 1 or GTR grade 2, gets F54 gray. H high risk, any grade 3 or stray current grade 2, gets S60 gray. LIHOFS.
Perfect. Pearl 4, the grade 2 GTR controversy. Bottom line, adjuvant RT is strongly recommended. Why? High recurrence, 50% at 5Y with surgery alone versus excellent control with RT. 94% through IPFS with 54 GO 0539.
Pearl 5, RTG with 0539 volumes recap. For GTR grade 2, intermediate risk 54G. CTV is GTV plus 10 millimeters reducible. For STR grade 2 or any grade 3 high-risk 60 gyne, CTV expansions are larger, often GTV plus 10-20 millimeters depending on PTV, reflecting high risk.
Pearl 6, re-irradiation. Yes, it's feasible, but counsel about the radionecrosis risk up to 20% at 2 years. Common doses are hyperfractionated, 25-35 theory guy and 5 extractions with very tight margins.
Pearl 7, planning pearls. GTV include nodular dural enhancement and hyperososis. GTV excludes edema and linear dural tail. T1 pre-contrast MRI is key for bone invasion. And consider gallium-68 dotatate PET for SSTR2 positive tumors.
And our final pearl, number 8, future directions. Keep an eye on molecular classification beyond WHO grade, those promising SSTR-targeted therapies like lutetium dotatate, and the evolving role of immunotherapy and other targeted agents. The field is moving fast.
Great pearls, ready for a quick board blitz.
Let's do it. Question 1. A meningioma is resected. Path report. 6 mitosis per 10 high-power field, and brain invasion is identified. What's the WHO grade? A, grade 1, B, grade 2, C, grade 3, or D. Cannot be determined without molecular markers.
Okay, the best answer is B, grade 2, the reasoning, brain invasion. As we said, the presence of unequivocal brain invasion automatically makes it WHO grade 2, regardless of anything else. Even without invasion, 6 mitosis falls within the 419 range for grade 2 anyway. So definitely grade 2.
Perfect. Question 2. 50-year-old patient, Simpson grade 4 resection of a WHO grade 2 meningioma. According to RTOG 0539, what's the risk group and dose? A, low risk, observation. B, intermediate risk, 54 GI. C, high risk, observation. Or D, high risk, 60 GI.
The best answer here is D, high risk, 60 GI. Why? Simpson grade 4 means subtotal resection. A subtotal resection of a WHO grade 2 tumor puts the patient directly into the high-risk group 3 category of RTOG 0539. And the treatment for that group was 60 grays in 30 fractions.
Excellent logic. Final question, number 3. You're counseling a patient about recurrence risk for a newly diagnosed WHO grade 2 meningioma after a GTR. Based on retrospective series, what's the approximate 5-year local recurrence rate if no adjuvant radiation is given? A, 10%, B, 10-20%. C, 20-30%, or D, approximately 50%?
And the answer is D, approximately 50%. This really hits home the core issue of the grade 2 GTR controversy. That high 50% 5-year recurrence rate with surgery alone is the main driver for strongly considering adjuvant radiation, aiming to improve on that number significantly, as shown in RTOG 0539. It's a critical statistic to know. So, wrapping up today. We've covered a lot of ground on meningioma management. We really dissected the WHO grading, including those newer molecular criteria for grade 3. We looked at Simpson grades, and of course spent significant time on the landmark RTOG 0539 trial, the risk groups, the doses, the volumes.
And we tackled that grade 2 GTR controversy head-on, looked at re-irradiation, and shared practical planning pearls. Hopefully everyone listening feels better equipped to handle these complex cases.
Absolutely. And maybe a final thought to leave everyone with. As radiation oncologists, how do we best navigate this? How do we integrate the emerging molecular data, the new systemic therapies, into our current evidence-based practice for higher-grade meningiomas? Balancing these potential new benefits with the proven efficacy of radiation we've relied on.
That's a great question. Definitely something to keep thinking about. And looking ahead, our next session will continue exploring non-glioma tumors. We'll be tackling pituitary adenomas and vestibular schwannomas.
2 more important topics.
Indeed. So be sure to check out the practice oral boards at radoncsmartlearn.com and subscribe to Radonc's Smart Review for that next session. Thanks everyone for tuning in.
Thanks for listening.